Welcome everyone to ISN Eastern and Central Europe Regional Webinar, Part 1. Good afternoon to all of you. And this afternoon we will be talking about 2020 KDIGO guidelines for the treatment of glomerular diseases. I have three distinguished speakers who kindly actually accepted our invitation to be a part of this webinar. We are grateful to them. We have Professor Rosanna Coppo, who is also the Deputy Chair of Western Europe region of ISN, and she's the Director of Nephrology, Dialysis and Transplantation at Regina Margherita Children's University Hospital, Turin, Italy. Then we have Dr. Andreas Kronbichler from Department of Internal Medicine, Medical University of Innsbruck, Austria. And finally, Professor Kultigin Turkmen from Necmettin Erbakan University, Konya, Turkey. But I would also like to thank Professor Vladimir Tesar, who is the Deputy Chair of our region and ISN headquarters, for making this webinar series real. Without their efforts, we would not be here this afternoon, and I'm grateful to them. And before discussing about the ISN, some logistics to our participants, attendees. We are thankful to them as well. If you have any questions, please use the chat box, and during the webinar, please mute yourselves. And I'll be directing the questions at the end of the session, which is going to be taking an hour and 15 minutes, to our speakers, and I will try to help you with any questions. If you cannot fulfill these questions at the meantime, I'll do my best to get your answers back to you as well. So here you see our ISN. We're celebrating the 60th year of International Society of Nephrology, and our vision is providing equitable access for sustainable kidney health worldwide. And we're trying to bridge the gaps and build capacity and connect communities, such as this afternoon. And as ISN, we have 10 regional boards, and ISN Eastern and Central Europe is one of those regions with 19 countries. And I'm sure I'm seeing some friends, colleagues joining us for this webinar. Because of this COVID-19, we cannot see each other and have chats, regular chats, or drink coffee or tea during our meetings. We have these virtual meetings, but they are as fruitful as our CME courses. So please enjoy the first speaker, Professor Rosanna Coppo. Please go ahead.
Thank you very much. Thank you very much for this kind invitation to share with you the last news on IgA nephropathy and IgA vasculitis. First of all, the 2020 preliminary consideration, KDIGO, are that IgA nephropathy is the most common primary IgA nephropathy, as we know, but most of the case, the progression is typical of a slowly progressive disease. It is heterogeneous from clinical and pathological features, and there are differences across the ethnic populations. In 2012, the value of clinical and pathology data was not clearly defined. Conversely, in KDIGO 2020, the first practice point for diagnosis is to use the revised Oxford Mass classification to score kidney biopsy. We know that the added value of the pathology variables in predicting the renal outcome on top of clinical data. Indeed, several risk scores have been developed to predict kidney outcomes in IgA nephropathy, but most of them are based on data from single race, and they did not use the MAST classification. That's why the KDIGO chose a tool originated by the analysis of IgA nephropathy multi-ethnic cohort of about 4,000 patients gathered by the International IgA Network Collaboration and divided into derivation and validation cohorts, which were able to produce this prognostic tool, which is accessible by a mobile Apple calculator or web-based calculator. Indeed, including age, sex, race, GFR, blood pressure, proteinuria, and MAST score, this tool can calculate the risk of composite endpoint, 50% decline in GFR of end-stage renal disease at 5 years. And this mean prediction value at 5 years correspond to a GFR decline and allow the classification of patients into various risk subgroups of low risk, intermediate risk, high risk, highest risk. Unfortunately, the many other prognostic serum and uranium biomarkers which were tested in the past were found to be not valid for prognostication, but the value of GFR and proteinuria is very high. So the difference between these new KDIGO guidelines are that the clinical and pathology features are indeed useful to assess prognosis in IgA nephropathy. But what about treatment? Well, this KDIGO focus on the common form of IgA nephropathy with a slowly progressive course, in which the primary focus is the management on optimized supportive care. That means give lifestyle advice, including information, dietary sodium restriction, smoking cessation, weight control, exercise is appropriate. For the other variants of IgA nephropathy, as IgA nephropathy associated with minimal change of acute kidney injury or rapidly progressive form, there are specific guidelines. But for the common form, first of all, we have to treat the blood pressure, and the blood pressure goal is now set down to 120 milliliter per mercury, and in children less than 50% of arterial blood pressure. But if the patient has proteinuria higher than 0.5 grams per day, the recommendation is to initiate therapy with angiotensin converting enzyme inhibitor or receptor blockers, but not both drugs. The proteinuria was set to a threshold of 1 gram per day in the KDIGO 2012. Now, the recommendation to start treatment when proteinuria is higher than 0.5 grams per day, irrespective of the presence of hypertension, again using angiotensin receptor blockers. Indeed, an individual patient meta-analysis reported that the reduction in proteinuria was associated with improved clinical outcome, which was independent of change in blood pressure. From the practice point of view, KDIGO state that proteinuria reduction under 1 gram per day is a good surrogate marker for improving outcome in IgA nephropathy. So when we define the diagnosis of IgA nephropathy, we exclude secondary cause, we score the kidney biopsy, we have to focus on this optimized supportive care, as I mentioned before. This is the first important step. But what about corticosteroids? In KDIGO 2012, there was the suggestion that when patients had persistent proteinuria higher than 1 gram per day, despite 3-6 months of optimized supportive care, and what GFR was higher than 50, they should receive a 6 months course of corticosteroid therapy. In 2020, again, there is a suggestion, again for the same therapy, but what is different is that the maximal supportive care is the first focus, and the second important point is to define treatment toxicity in the patient. So we have to discuss with the patient the risk-benefit balance, and there is important recognition of the adverse effects. There is unfortunately insufficient evidence of the MSC value in treatment choice. And the KDIGO stressed the relevance of the dynamic assessment of patient risk over time, since the clinical condition can change, and so the treatment decision can change as well. Why this modification? Well, first of all, because we had the report of the STOP IgA nephropathy trial, in which 30% of patients improved after the maximized supportive care and were not being able to be enrolled because the proteinuria was too low. And in the other, there was a significant benefit in immunosuppression in getting the full remission. However, there was no significant benefit for what is concerned the decrease in GFR of at least 15 milliliter per minute. The same group has recently published the 10-year follow-up of these patients, 72 and 77 patients, which, apart from the 3 years of the trials, had a median follow-up of 7.5 years. The data were collected by a questionnaire, and the treatment was not controlled or partially controlled, in 30% of the cases not controlled at all. But what was relevant was that they changed the primary outcome. And they used a hard outcome as death and stage renal disease, 40% reduction in GFR, And they found that there was no difference between the patient who had supportive care only or supportive care plus corticosteroid immunosuppression. 50% and 45% of these patients respectively got to determine this hard endpoint. And also for what is considered the secondary endpoint, no difference between supportive care and treatment arm was observed. On the contrary, there were some adverse events and also death from pneumogenic cystic sepsis, which was considered a serious adverse reaction. The conclusion from controversy conference were that corticosteroid immunosuppressive treatment induced transient reduction in proteinuria over 3 years, but had no impact on renal function, and the optimized supportive care induced such a slow loss of GFR, which rendered the STOP IgA nephropathy study underpowered to detect an additional potential benefit on GFR protection using corticosteroids or immunosuppressive drug. And everybody was worried about the increase in significant adverse events. And this was further stressed by the testing trial, which was prematurely interrupted because of the high frequency of side effects in spite of some benefits. But these side effects, which were mostly infections, were significantly different in the group treated with prednisone induced the previous discontinuation due to this high risk of adverse events in 14% of the group treated with methylprednisolone versus 3% in placebo, in spite of the significant protection from 40% GFR decline, also in patients with low GFR. And for most of all, there was a significant increase in infections, including 2 deaths. So we are looking to see the results of the testing low dose trial, which will hopefully be published not very far away. Based on this data, the KDIGO 2020 were very careful about corticosteroids, since at this point the clinical benefit of corticosteroids in IgA nephropathy are not established, and corticosteroids should be given with extreme caution or avoided entirely in the following situation, like low GFR, diabetes, obesity, latent infection like viral hepatitis, secondary disease like cirrhosis, active pulp, peptic ulcerations, uncontrolled psychiatric illness. And when appropriate, treatment as a prophylaxis against pneumocystis carini pneumonia should be adopted. But anyway, when proteinuria persists in spite of supportive care, when you exclude the other form in which the corticosteroid therapy is not applicable, at the end, we really discuss the risk-benefit with the patients, and the risk-benefit profile is acceptable, corticosteroids are the choice. But these 220 guidelines include a new specific population analysis. And this is relevant for the variants of corticosteroid therapy. Indeed, the KDIGO 2012 gave no indication to use other immunosuppressive agents, in particular not to use mycophenolate in IgA nephropathy. Conversely, now focus was made on Chinese patients in which mycophenolate was suggested to be used in the same case. This was after the analysis of the beautiful study produced by the Xiong Liu group. They randomized patients to prednisone or prednisone half dose and mycophenolate 1.5 grams per day. But what was of interest that included incident patients with biopsy within 1 month, patients with active disease with crescents, endocapillary hypercellularity, glomerulonecrosis, and a low degree of tubular atrophy. And the primary endpoints were completely different. They were complete remission or change in active proliferation lesions on repeated renal biopsy, which was detected in both groups. So they concluded that mycophenolate plus prednisone half dose induced fewer adverse events with similar benefits in patients with active proliferative lesion as full prednisone doses. Another point which was much discussed in the KDIGO 2012 was tonsillectomy, there was no suggestion, or the suggestion not to use, not to perform tonsillectomy in IgA nephropathy. In 2012, multiple cohort studies were considered from Japan particularly, in which they reported a benefit in hematuria remission and proteinuria remission, as well as in renal function outcome, particularly in early cases. So the practice point of view is that this benefit in Japanese patients has to be considered, even though tonsillectomy should not be performed as a treatment for IgA nephropathy in Caucasian patients, given to the evidence we have. Special conditions include IgA nephropathy associated with minimal change disease. The treatment should be the same as minimal change. Or IgA nephropathy associated with Membranoproliferative Glomerulonephritis. Those patients should be treated as high-risk patients. Or conversely, in some cases, there is a high proteinuria without nephrotic syndrome, and KDIGO said to consider the possibility of focal segmental glomerulosclerosis as a secondary form. Another special condition is IgA nephropathy associated with acute kidney injury, particularly after gross hematuria with persisting renal function reduction after 2 weeks from the first episode, or in case of rapid decrease of GFR due to, in this case, to stent secretion formation. So there is the indication to perform a kidney biopsy, to repeat kidney biopsy, because maybe we have to move for a more active treatment. And this opened the question to presenting IgA nephropathy, which was again a point discussed in KDIGO 2012. Presenting IgA nephropathy were defined as disease with more than 50% of glomeruli with renal crescents, and it was suggested to use a treatment similar to ANCA vasculitis. In KDIGO 2012, the practice point considered the decline of GFR, more than 50% decline in GFR over 3 months or less, as a sign of rapidly progressive IgA nephropathy. In this case, it is common to find mesangial in the capillary artery cellularity and presence, but the two pathology features and clinical features should be associated. And in this case, the suggestion is to use cyclophosphamide and corticosteroids as in ANCA-associated vasculitis, while there is insufficient evidence to support the use of rituximab. KDIGO 2012 considered also the pregnancy planning, so RAS inhibitors should be cessated, and in case of planning conception and an active IgA nephropathy, it should be worthwhile to try an immunosuppression to optimize immunological activity before conception. KDIGO considered also children this time. And in children, the treatment with renin-angiotensin system blockers have to be considered when proteinuria is higher than 0.2, so at low levels. And when proteinuria is above 1 gram, but in association with mesangial hypercellularity, most of the nephrologists would use corticosteroids in addition to renin-angiotensin system inhibitors. And obviously, in case with rapidly progressive course, the therapy should be the same as in adults, with prompt use of steroids and immunosuppression. There is a recommendation to continue the follow-up of patients even after complete remission, as children can relapse even after many years. Short notice about IgA vasculitis. In KDIGO 2012, 2 points were very relevant. The recommendation not to use corticosteroid to prevent the so-called henochondrial nephritis, and the suggestion to use in adults the same protocol as in children. The recommendation remains very strong not to use corticosteroid to prevent nephritis in adults and children with isolated extrarenal IgA vasculitis. And when there is a renal involvement, if the nephritis do not have a rapidly progressive course, the treatment should be the same as for primary IgA nephropathy, based on renin-angiotensin system inhibition. When there is a persistent proteinuria, high risk of progression, again, the same line of careful advice to use corticosteroids, similar to IgA, primary IgA nephropathy. But in IgA vasculitis, the rapid depressive course is more frequent, particularly in children, but anyway. So the treatment in these cases should be as for ANCA-associated vasculitis as for rapidly progressive primary IgA nephropathy. KDIGO focused on cases with significant extrarenal involvement, and in this case, with the severe extrarenal complication, the treatment should be more relevant. And finally, for management of children with IgA vasculitis, mostly based on the European Consortium initiative, which stated that there is a delay in biopsy and treatment longer than 30 days may be harmful. And so a biopsy should be quickly performed when the children are active, and even in case with mild or moderate IgA vasculitis, there is suggestion to use corticosteroids and use intravenous pulses or cyclophosphamide when there is a nephrotic syndrome or a rapidly deteriorated renal function. So let me thank the chair of this new guideline, Jürgen Flöge and Rovin, and the outstanding working group, which performed very excellent work. Thank you for your attention.
Thank you, Rosanna, for this informative talk. We know your efforts and contribution to the literature in the IgA nephropathy, and I'm sure that we will be receiving some question afterwards. So we move forward to our next speaker, Dr. Andreas. Please, we are expecting to hear your presentation.
So thank you for the opportunity to speak here, and my topic is membranous nephropathy. And of course, this disease has been studied quite well the last couple of years. So at a glance, there has been quite a change in the KDIGO guidelines. So from actually quite a lot of statements and different points, this has been narrowed down to 4 different categories. So diagnosis, prognosis, treatment, and special situations within the draft guidelines. But overall, the amount of pages has, of course, increased. So the diagnosis has been revolutionized by the discovery of phospholipase A2 receptor antibodies by Lawrence Beck in 2009, published in the New England Journal of Medicine, and they found in 26 out of 37 patients that Western blot could detect phospholipase A2 receptor antibodies. During the past couple of years, commercially available assays have been proposed, and one is the IFD test, the other one is the ELISA test by Euromin, which is probably the best way to characterize our patients. So IFD is just giving you a semi-quantitative score, while ELISA can actually show you the total amount of BL2 receptor antibody titer. A titer above 14 is considered as positive, and if you have values between 2 and 14, these results are equivocal and a retesting is advised. In the case of phospholipase A2 receptor positivity, the guidelines advise that you should measure phospholipase A2 receptor antibodies every 3 to 6 months. But in cases with higher levels, you should perform testing at shorter intervals. If you have disappearance of phospholipase A2 receptor antibodies, patient will have immunologic remission and will see a clinical remission during follow-up, and you don't need to apply additional therapy. While patients with persistence of phospholipase A2 receptor antibodies might have persistent disease activity, and you should reconsider therapy. But we are coming back to treatment in a few minutes. So this has been based basically on this study by Pierre Ronco and Jack Wetzel's group, published a few years ago in Kidney International. And you can see on the left-hand side patients receiving cyclophosphamide treatment and patients with rituximab treatment. And here they showed that if patients had higher titers of phospholipase A2 receptor antibodies, the disappearance rate was higher following cyclophosphamide compared to rituximab, and those in the highest group haven't been negative during follow-up. You can see at baseline, proteinuria among these patients were quite similar. So the new guidelines state that if you have a negative phospholipase A2 receptor antibody test and a high likelihood of membranous nephropathy, go and perform a biopsy. If you have a positive test and normal kidney function, don't perform a biopsy. Biopsies should be performed in different clinical scenarios, like if immunosuppressive therapy is considered or might be changed, patients present with AKI, unusual clinical course, positive ANI, or persistent nephrotic syndrome, for instance. So based on this study from Hamburg and also from Fernando Ferenza's group at the Mayo Clinic, these guidelines have stated that no biopsy is needed if you have a positive phospholipase A2 receptor antibody test and a preserved eGFR of over 60 milliliters. They actually investigated 194 patients here, and you can see on the left-hand side no additional diagnosis in 182 patients, additional diagnosis in 12 patients, and these patients had higher proteinuria, a more impaired renal function, as can be seen here with a higher serum creatinine, a lower GFR, and lower phospholipase A2 receptor antibodies. In these cases, 5 patients had additional interstitial nephritis, 5 patients had additional diabetic kidney disease, and 2 patients presented with concomitant IgA nephropathy. So regardless of positivity for phospholipase A2 receptor antibodies or thrombospondin type 1 domain containing 7A antibodies, basic screening for malignancies is still recommended. This should include ultrasounds of the kidneys, then X-ray or CT scan of the lungs, and the patient should undergo a national screening program for breast and colon cancer, and in patients over 50 years and male sex, a PSA test should be done. Moreover, full history and full examination should be performed, ANA test should be performed, and of course a history of drug use should be investigated. The prognosis is based on different risk categories, and the low risk group, moderate risk group, and high risk group are basically characterized by a GFR and proteinuria, while you can see on the right-hand side the very high risk group is also based on life-threatening nephrotic syndrome, massive deterioration of kidney function, high loss of molecular weight, proteinuria, while for instance in the low risk group you have normal GFR, proteinuria in the subnephrotic range, and preserved serum albumin. So prognosis, and this is important in most patients, is reasonable to wait for 6 months for spontaneous remission. If patients present with high levels of proteinuria, high levels of phospholipase A2 receptor antibodies, although molecular weight proteinuria characterized by high levels of alpha-1 and beta-2 microglobulin in the urine, a preliminary treatment should be re-evaluated. But it's important to state that if patients present with proteinuria over 4 grams per day, the chance of spontaneous remission is almost 50%. If they present with over 8 grams per day, the chance of spontaneous remission is around 33%. And you can see that even in patients with high levels of phospholipase A2 receptor antibodies, the chance of remission is there without treatment. Treatment is simplified in the current KDIGO guidelines. Every patient should, of course, receive supportive care treatment. That means ACE inhibitors or ARBs. And then patients should be evaluated according to the risk score. So in low risk score, wait and see if patients achieve spontaneous remission. If patients present with moderate risk, wait and see strategy is also possible, but the guidelines recommend rituximab or CNIs. If patients are in the high risk group, patients should receive rituximab, cyclophosphamide, or CNIs plus rituximab, as has been used in the STARMAN trial. And if patients are in the very high-risk group, patients should receive cyclophosphamide derived on the study from Jack Vettel's group, as shown before. So the guidelines state that immunosuppressive therapy is not required in patients with MN, nephrotic syndrome, and normal eGFR, unless at least one risk factor for disease progression is present, or unless serious complications of nephrotic syndrome have occurred. For patients with membranous nephropathy and at least one risk factor for disease progression, the guidelines recommend using rituximab or cyclophosphamide plus steroids for 6 months, or a tacrolimus-based therapy for at least 6 or 12 months, with a choice of treatment depending on the risk estimate. The timing of treatment starts, the type of drug, and the duration of therapy is depending on risk estimates, patient characteristics, patient and physician preferences, reimbursement policies, and societal perspective. So treatment, and these are commonly used treatment regimens in membranous nephropathy, and you can see here that if you use cyclophosphamide as cyclical therapy, for instance, and you assume that your patient is 90 kilogram heavy, as I am, you end up to have a cumulative cyclophosphamide dose here in the Ponticelli regimen of around 20 gram. If a patient weighs 60 kilogram, the cumulative dose is still 13.5 gram. This has been calculated for the continuous group, and different strategies for rituximab are available. As you know, the single dose B-cell targeted regimen, mainly published from the Bergamo group, has also achieved good remission rates, but also the non-Hodgkin lymphoma regimen has been used. So the treatment is quite complex, and if you can see here, if you apply the 3 different options, so rituximab, tacrolimus, or cyclophosphamide, you should measure antibodies after 3 months. If they are absent, you should stop cyclophosphamide, no additional rituximab, but continue tacrolimus for at least 9 more months. After 6 months, absence of antibodies or low titers continue as per guideline. If there is no change in antibody titers after 3 months, extra dose of rituximab might be considered. Continue cyclophosphamide, continue tacrolimus. If there is an increasing titer after 6 months, additional therapies with standard agents can be used. But, and this is important, if you use cyclophosphamide, the cumulative dose should not exceed 25 grams, and lower doses, maximum 10 grams, is advised if patients wish to conceive. But as I've shown you before, this is really not achievable in patients with a weight of 50 kilogram or above. If there are increasing titers, you might consider to add on cyclophosphamide, and if the titers are further increasing, you should evaluate and treat the patient as a resistant disease. Management of initial relapse, and if you used rituximab before, repeat rituximab CNI, you can add on rituximab to your CNI, and if you've used cyclophosphamide, you might consider cyclophosphamide again, but you can also switch to rituximab plus tacrolimus. Management of resistant disease, and here it gets more complex, and as you can see, cyclophosphamide has a very prominent role here if eGFR is decreasing. So if you've used rituximab, eGFR is decreasing, use cyclophosphamide, CNI the same, and if you've used cyclophosphamide, eGFR is decreasing, you might use cyclophosphamide again. If your patient is resistant, eGFR is stable, you might switch to rituximab. And here, importantly, you should probably consult an expert center. The special situations here are quite complex. For instance, in a kidney transplant recipient, If you have known phospholipase A2 receptor antibody-associated membranous nephropathy, measure your levels. If they are positive, you get a very high risk of recurrence of approximately 50%. If these are negative, but you know that your patient had levels before and they've disappeared, the risk is quite low. And if there is negativity to phospholipase A2 receptor antibodies, you have a median risk of recurrence of around 30%. Peri and post-transplant monitoring, you should measure proteinuria every month, and if proteinuria is over 1 gram per day, you should perform a kidney biopsy. If the phospholipase A2 receptor antibodies are increasing, also the likelihood of recurrence is increasing, and you should consider an early kidney biopsy, even if proteinuria is low but exceeding 0.3 gram per day. Treatment of recurrence is, of course, again, conservative treatment, optimize immunosuppression of your patient. And if patients do have a proteinuria over 1 gram per day and you have biopsy confirmed membranous recurrence, you should consider rituximab treatment. In children, performance of a kidney biopsy is necessary. The wait and see strategy with supportive therapy is usually not adopted in children. Patients should be treated with higher doses of steroids, and you might use rituximab or calcineurin inhibitors. If patients are antibody positive, so BLR2 receptor antibody positive or thrombospondin type 1 domain containing 7A positive, you should monitor these titers. And if patients present with very early onset, you might consider that PSA antibodies are present. Prophylactic anticoagulant therapy in membranous nephropathy, and here you should actually look if your laboratory measures albumin with bromcresol purple or bromcresol green, as these are different measures and do display almost the same range of albumin. If your albumin levels are higher, so below 30 gram but above 20 gram here, and the arterial thromboembolic event risk is quite high in your patient, you should give him aspirin. If you have low risk or higher albumin levels, no aspirin is advised. If patients do have low albumin of below 20 gram per liter and do have a high risk of venous thromboembolic events, please assess the bleeding risk, but this home batch is down at the moment. And you have low risk, warfarin or low molecular white heparin plus aspirin in your patient. So this has been advised by Jack Wetzels and Julia Hofstra a few years ago in Kidney International, especially if patients have a serum albumin below 3.2 gram per deciliter and they have a high atherothrombotic event risk based on Framingham risk score, which includes age, smoking, cholesterol and blood pressure, EGFR, diabetes and previous events. You should put your patient on aspirin therapy. So research recommendations include several different forms, treatment, prognosis, but also diagnosis, and one is to identify additional antigens in your patients with membranous nephropathy. And this is a summary slide which has been shown at the ASN recently. So 70 to 80% of all comers with membranous nephropathy will have a positive phospholipase A2 receptor antibody. And among the negatives, you see different forms of antigens have been identified, like thrombospondin type 1 domain containing protein 7A, but also NEL1, and in older patients, high temperature recombinant protein A1. In patients with an autoimmune history, exostosin 1 and 2 has been identified to be present in membranous lupus nephritis, but also a new antigen with neural cell adhesion molecule 1 has been identified. And in children, semaphorin 3B antigen as an antigen has been identified recently and published in Kidney International. And here you have associations with hematologic malignancies as well. So to conclude, the current guidelines have revised the role of a kidney biopsy, making the diagnosis of membranous nephropathy. Prognosis depends on risk classification. The guidelines have actually adapted the critical role of phospholipase A2 receptor antibodies in membranous nephropathy and their role in predicting clinical remission. They have emphasized the central role of rituximab in the management of membranous nephropathy, but also left a lot of space to cyclophosphamide, especially in those with very high titers. And the ASN has presented the results of the Salmon trial, which has shown that cyclophosphamide-based induction therapy has led to more remission rate, or the higher remission rate compared to tacrolimus plus rituximab after 6 months. So cyclophosphamide still plays a huge role in the management of membranous nephropathy. Thank you very much.
Thank you, Andreas, for your nice talk. And we will move forward to Kultigin, and then we'll take any questions, and everyone can write us their questions through the chat box, please. Thank you.
Good afternoon to everyone. First of all, I would like to thank the organizing committee for inviting me this beautiful webinar. Today, I will mention about the update on complement-related glomerulopathies regarding the comparison between KDIGO 2012 and 2020 guidelines. My presentation will include the history of MPGN and C3 glomerulopathy, and I will also mention the importance of the new definitions, and I will compare two guidelines in terms of the diagnosis, evaluation, and treatment of MPGN and C3 glomerulopathy. And I will lastly mention about the gaps in the field. As you see here, at least there are 7 different entities related to complement-associated glomerulonephritis, but I will focus only 3 of them today. First of all, I will mention about the definition and the history of membranoproliferative glomerulonephritis. In the early 1970s, for the first time, Cameron's group showed us that MPGN is related with persistent hypocomplementemia. And formerly, MPGN is also named as mesengiocapillary or lobular glomerulonephritis. This entity typically includes mesangial hypercellularity, endocapillary proliferation, and capillary wall remodeling with mesangial interposition and duplication of glomerular basement membrane. It consists of 7 to 10% of glomerulonephritis. MPGN can be represented by asymptomatic hematuria, nephritic or nephrotic syndrome, or rapidly progressive glomerulonephritis. And we know that previously, this entity classified into 3 types as type 1, type 2, and type 3. Type 1 is the most common seenly type, and this type includes subendothelial deposits contain immunoglobulin M and G, and complement components also. However, in type 2, which consists of intramembranous deposits, contain only complement components, and type 3 also includes subendothelial, intramembranous, and subepithelial deposits of C3, either alone or in combination with immunoglobulins. However, since both primary and secondary MPGN classification do not depend on disease pathogenesis, so problems arise in clinical and histopathological studies. For the first time in the literature, Serve and his colleagues demonstrated that some patients with MPGN did not have immune complexes, and they had only C3 deposition in glomerular basement membrane and mesangium. This novel finding forced the researchers to a reclassification of MPGN. And Fadi Fukari's group, as a new opinion, showed a new classification of MPGN as an immunoglobulin-mediated disease and non-immunoglobulin-mediated disease. This reclassification led to the improvement of diagnostic and medical algorithms, and this new group was represented by the same group as C3 glomerulopathy, which consists of dense deposit disease and C3 glomerulonephritis. As we see here, the pathological features of idiopathic MPGN, dense deposit disease, and C3 glomerulonephritis is very different from each other. In idiopathic MPGN, we can see glomerular complement and immunoglobulin staining. However, in dense deposit disease, we can see only C3 staining with little or no immunoglobulin staining. And also in C3 glomerulonephritis, we can see only isolated glomerular C3 staining without immunoglobulin or C1q staining. And although dense deposit disease and C3 glomerulonephritis are morphologically distinguishable, they are now considered as a part of the same etiologic spectrum. However, dense deposit disease have worse outcomes compared to patients with C3 glomerulonephritis. And for the first time, Mayo Clinic group have used mass spectrometry of glomeruli, which is isolated by laser microdissection from cases of dense deposit disease, and they showed that these glomeruli contain components of alternative complement pathway and terminal complement components. This finding showed us the importance of the classification of MPGN based on the presence and absence of immunoglobulin in immunofluorescence microscopy. And this MPGN reclassified by this same group, by Sanjeev Setsi group, into two main subgroups. First of all, they classified MPGN by immune complex mediated MPGN, which is primarily driven by complement components, especially secondary to chronic antigenemia or circulating antigen antibody complexes. And the second group of MPGN without immunoglobulin deposits, which is also driven by alternative complement pathway or activity. What we have learned from these studies, glomerular pathology associated with isolated C3 accumulation is more heterogeneous than previously thought, and traditional electron microscopy based classification can result in overlap among types, and hypothetically, complement inhibitor treatment might be beneficial, especially in patients that alternative pathway play a critical role in the pathogenesis. From this point, I will compare two guidelines in terms of C3 glomerulopathy and immune complex mediated glomerulonephritis. The previous KDIGO guideline showed us the causes of MPGN as chronic infections, especially hepatitis C, and autoimmune diseases, especially lupus nephritis, monoclonal gammopathies, especially light chain deposition disease and monoclonal immunoglobulin G disease, and complement dysregulation, especially complement factor H deficiency, and chronic and healed thrombotic microangiopathies. However, in the new guideline, this group is classified into four subgroups. The first group is immunoglobulin, immune complex mediated disease, which is closely related with deposition of antigen antibody immune complexes as a result of infection. And these also immune complexes can be secondary to autoimmune disease. and also deposition of monoclonal immunoglobulins as a result of monoclonal gammopathy due to plasma cell or B cell disorders. And this entirety also can be secondary to fibrillary glomerulonephritis. The second major group is complement-mediated glomerulonephritis, including C3 glomerulonephritis and C3 dense deposit disease, and C4 glomerulonephritis with C4 dense deposit disease. The third group includes MPGN without immune complexes or complements, which is especially occurs due to various disease. And the fourth group includes idiopathic forms of MPGN, which is not associated with the other groups. And when we check the evolution of MPGN and C3 glomerulopathy, the previous KDIGO guideline and also a consensus report published by the same group in 2017, complement investigation in C3 glomerulopathy should include the measurements of serum C3 and C4 levels, and also measurement of C3 nephrotic factor and serum factor H, and also serum paraprotein detection and screening for complement factor H related 5 mutations. In the new guideline, this complement investigation also includes some other components like serum MAC levels and C3D and BB levels, and also some factors including factor H, I, F, and properdin. Also, genetic testings like C3, complement factor H, I, and B, and complement factor H-related protein 5. And the new guideline also suggests us to evaluate patients with glomerulonephritis and monoclonal immunoglobulin deposits for a hematological malignancy. And they also suggest if no underlying etiology is found for immunoglobulin immune complex glomerulonephritis after extensive workup, evaluate the patients for complement dysregulation. Also, the new guideline suggests us to rule out infection-related glomerulonephritis or post-infectious glomerulonephritis prior to assigning the diagnosis of C3 glomerulopathy. And they also suggest us to evaluate for the presence of monoclonal proteins in patients who present for the first time with a C3 glomerulopathy diagnosed over 50 years of age. What about the treatment? The previous guideline suggests us to treat all patients for optimal blood pressure control below 120/80 millimeter mercury in adults, and they suggest us to use ACE angiotensin converting enzyme inhibitors and angiotensin receptor blockers. And they also suggest us lipid control and optimal nutrition for both normal growth in children and healthy weight in adults. The new guideline suggests us, especially in indolent immune complex glomerulonephritis, whether idiopathic or linked to a primary disease process, they suggest us treat our patients with supportive care with RAS blockers, and only carefully consider the use of immunosuppression in these patients. The previous guideline described moderate disease as urine protein over 500 milligram per day despite supportive therapy, or moderate inflammation on renal biopsy, or recent increase in serum creatinine suggesting risk for progressive disease. They recommend prednisolone and mycophenolate mofetil. We can choose one of them. The new guidelines especially suggest us if our patients with idiopathic immune complex glomerulonephritis and they have proteinuria below 3.5 grams per day, and they don't have any nephrotic syndrome, other components, and a normal GFR, they suggest supportive therapy with RAS inhibition alone. If our patients with idiopathic immune complex glomerulonephritis with a nephrotic syndrome and normal or near normal serum creatinine, we should try a limited treatment course of corticosteroids. The previous guideline described severe disease as urine proteinuria over 2,000 milligrams per day despite immunosuppression and supportive therapy, or severe inflammation represented by marked and/or extra capillary proliferation with or without crescent formation despite immunosuppression and supportive therapy, or increased serum creatinine suggesting risk for progressive disease. They recommended methylprednisolone pulse as well as other anticellular immunosuppressants, and they suggest us that the data are insufficient to recommend eculizumab as a first-line agent for treatment of rapidly progressive disease of MPGN. The new guideline suggests us, especially our patients, if our patients have idiopathic immune complex glomerulonephritis with abnormal kidney functions but without crescentic involvements, or active urine sediment with or without nephrotic proteinuria, they suggest corticosteroids plus immunosuppressive therapy and plus RAS blockers and other supportive care. If our patients presenting with rapidly progressive glomerulonephritis and crescentic glomerulonephritis, they suggest treatment with high-dose corticosteroids and cyclophosphamide. For most patients with idiopathic immune complex glomerulonephritis presenting with an EGFR below 30 milliliter minutes per 1.73 meter, we should treat these patients with supportive care only. We shouldn't give any immunosuppressive therapy or eculizumab therapy. And the new guideline suggests us using eculizumab only in the absence of monoclonal gammopathy, and these patients should treat it initially with MMF, then we can choose eculizumab if this fails. You can see the eculizumab therapy studies here. Several case reports and case studies supported the use of eculizumab in a subset of patients with C3 glomerulopathy. And one of the important study done by Bombeck's group from United States, this study shows us a single trial, open label proof of concept for efficacy and safety study. This study includes 3 patients with dense deposit disease, 1 patient with renal transplantation, and 3 patients with C3 glomerulonephritis. And of these patients, two of them had renal transplantation. All of the patients had proteinuria over 1 gram per day and or AKI at enrollment. And genetic and complement testing identified pathological variants in complement factor H and CD42 in 1 patient from each group. And C3 nephritic factor positivity also is seen in 3 patients. After 12 months of thrice-weekly eculizumab therapy, 1 patient with dense deposit disease and 5 patients with C3 glomerulonephritis showed reduced serum creatinine levels. And 1 patient with dense deposit disease had a marked reduction in proteinuria, and 1 patient with C3 glomerulonephritis had stable lab findings plus histological evidence of improvement. All patients who had elevated serum baseline C5p9 normalized with eculizumab therapy. And according to the results of this study, the authors concluded that some patients, but not all patients, responded to eculizumab therapy, and measuring C5b9 levels might be a useful marker to monitor eculizumab therapy. You can see the other important studies regarding the eculizumab therapy in C3 glomerulopathy. The main and common findings of these studies are not all patients respond well with eculizumab therapy. Only some of the patients show global or partial clinical responses. In the near future, we will see some other drugs targeting factor D or factor B or MASP2 to block these targets, and we will see the results of these studies in the near future. As you see here, the last one, avacopan, which is also a blocker of C5a receptor, also under investigation in some patients with C3 glomerulopathy. So what are the areas of controversy and gaps in the knowledge? Immunofluorescence staining is subjective and semi-quantitative. We should be very consider this subjectivity, and electron microscopy appearance of dense deposit disease is well defined, but C3 glomerulonephritis is not clear. Subepithelial hump-like deposit appearance on electron microscopy is uncertain and is not pathognomonic for post-infectious glomerulonephritis. There is evidence for C4D staining to distinguish C3 glomerulonephritis from immune complex mediated glomerulonephritis, but the role of staining C4D is not established, and more evidence are required. If possible for our labs, C3 breakdown products can be defined by immunofluorescence or mass spectroscopy. This method can also be used for factor H related proteins and C5, C9 terminal components, complement components. What are our take-home messages? Distinguishing C3 glomerulopathy from immune complex mediated MPGN is the first, should be the first step in guiding the workup algorithm. And further differentiation between dense deposit disease and C3 glomerulonephritis may help long-term prognosis. If we suspect from C3 glomerulopathy, we should do genetic testings with autoantibody testings and assessments of alternative pathway complement components. Also, acquired drivers in the form of autoantibody are the abnormalities most frequently associated with complement dysregulation, and genetic variants in C3, complement factor B, H, and I, and complement factor H rated 1 and T5 genes are potentially causal. Both rare and common variants coexist and associated with susceptibility of the disease. So we should check the genetic variants of these complement components. Post-infectious glomerulonephritis cannot be differentiated from C3 glomerulopathy by kidney biopsy alone. This is very important, and we should take treatment according to the diagnosis, and using immunosuppressive treatment or eculizumab useful in some patients, not in all patients. Thank you for your attention.
Thank you very much, Kultigin, for this informative talk. Could I please have all my speakers back on the scene, so I might have some questions to forward to you. Let me start with a practical question to Andreas, actually. And this is, you talked about phospholipase A2 receptor, looking into the serum levels of that marker. but when you order one for your patients, how long does it take? I know it differs from country to country or discipline. So do you wait for the results before you initiate your therapies for that patient, or do you wait for the results, and how to move forward with this marker actually? Any comments?
So in our laboratory, it takes around 7 to 10 days, working days, to get the results back. And usually I rely on the marker. We had one very old patient recently who had very high titers and received repetitive rituximab and now turned negative. And this is the best marker we have actually in autoimmunity, so predicting quite nicely actually treatment response, especially in my experience in rituximab treated patients.
Okay.
So yes, we check the titers. We perform biopsy in most patients still, but I think this is up to change actually in practice based on the results of these studies. So there is an update coming from Fernando Ferenza's group quite soon.
Yeah. Okay. A couple of more questions about this marker. One of the questions asked about if there is positivity for PLAR2R and the patients is with diabetes, would you still recommend a biopsy, and or would you move forward? Because we will have this controversy if it's going to be diabetic nephropathy or membranous nephropathy, but we know that on top of diabetic nephropathy, we might have, let's not put it that way, in patients with diabetes mellitus, we might have other glomerulopathies as well. So what would you suggest?
So if this patient is presenting with high level of proteinuria, you need to move forward and probably treat the patient. I would probably avoid steroids, so rituximab monotherapy would be probably a solution in this case, but you should probably treat the primary membranous as well. Yeah.
Okay. Rosanna, some questions forward to you. One of them is, what is the role of gluten enteropathy, celiac disease, and IgA nephropathy? Anything to tell about it?
Oh, well, it's a long story. Yeah.
Yes, I know, but a couple of words about it, and then I'll ask about the second question as well. They are asking about the use of hydroxychloroquine, and still, are there any room for tonsillectomies? Okay. Okay,
thank you. Well, the relationship between gut and IgA nephropathy is a long story. There is something true, that's for sure. So many studies has been devoted to this field that this is for sure a strict relationship in the target for therapy, which is reasonable. The direct relationship between celiac disease and IgA nephropathy is not so evident. There is something in common because the frequency of IgA nephropathy is much higher in patients with celiac disease than in other conditions. But anyway, not 30% of the case, but 4% instead of 0.2%. So the difference is there, but not a direct communication between the two diseases. But what is relevant is that the way or treatment may in some way go through the intestine, and this is the message. I strongly think that there is something true in that, and that will be useful for patients to go and see which is the best way to interfere with this gut-kidney axis. And then the second point is hydroxychloroquine, which is a very interesting drug there. The results from the LU groups are excellent indeed. The drug is useful, and particularly it's a drug which is without any serious side effect. It's well used. We used it for lupus nephritis for a long period, and we know that the ophthalmologic complication can be addressed by reducing doses and lower time of duration. So I think it's a promising drug, particularly for mild cases, and it should be used, and we are waiting for more consistent data. But for the moment it's actually a promising drug. And for tonsillectomy, indeed, in Europe and in the States, we don't have this experience because historically the story is relevant. In Japan, they used tonsillectomy because it was the only way adopted since years, decades, and so on. They do not have access to renin-angiotensin system inhibition still now. This is not covered by the public insurance. So they can use only partially, and in some cases when there is hypertension, this drug, which is largely adopted in our countries. So the results they had were in some way driven by the history, by the attitude expected by the population. The results are there. There is something right in the tonsil IgN axis. There is another way to activate the mucosal immune system, and the results they have are rather consistent for mild cases. But anyway, it is impossible in Europe to go for tonsillectomy in a person without any precise focal infection. In case of a problem, of a side effect, of a surgical problem, you may be suited. So for us, it's important. Thank you.
Okay, thank you very much. Kultigin, now I have a question for you. Do you think that we have data or enough data about C3 glomerulonephritis recurrence after kidney transplants?
It's a good question. Thank you for this question. Actually, we don't have the exact data about post-transplant C3 glomerulonephritis because this is a new definition. So our pathologists are not familiar with this definition, and they also say this is a MPGN, not C3 glomerulonephritis or C3 glomerulopathy. So I think this new definition should be teach to our pathologists. So we can see C3 glomerulopathy, of course, after renal transplantation, especially if it is related with complement, alternative complement pathway activation. And also, according to my experience, we see one patient who had a typical hemolytic uremic syndrome prior to her renal transplantation. Then he developed C3 glomerulonephritis after renal transplantation when we discontinue eculizumab. So this is, I think, important. We shouldn't discontinue eculizumab therapy after transplantation in some selected patients.
Okay, actually, this was the second question I was planning to ask you. They asked about, did you continue the eculizumab post-transplant period? And you said yes for the patients, and we actually got the answer back from you. And I think it's time that we stop now, and I see a couple of more questions. I'll try to do my best to divert the questions to the speakers, and I would like to thank all of the speakers in my name and Vladimir's name and the ISN-Eastern and Central Europe Regional Board. Thank you for being with us, attending our webinar. We hope to see you at the second part of this webinar, so stay safe. Till next time. Thank you very much indeed. Bye.
Thank you.
Thank you. Bye.
Bye. Bye.